on our international symposium. If all goes well, we will welcome you on the 26th or 27th of November in Le Plaza Hotel in Brussels. Our scientific committee has worked very hard to offer you some interesting topics. If you like to know more about the symposium, you can visit the Belsect website. We will post a link in the message board. But let's go back to the topic of this evening. Dimitri Thijs has specialized after his bachelor in nursing in OR, and he followed also an education as an anesthesiology technician in Rotterdam. He worked before he became a perfusionist in ZNA Middelheim, where he worked in Breda as an anesthesiology tech. He will bring tonight something about malignant hyperthermia, a rare but rather serious anesthesiologic emergency. If you have any questions, you can ask them in the Q&A section on the bottom right. So I will give the word to Dimitri so he can start.
Okay, thank you, Matthias. First, I'm going to share my screen and see if it works. Yes. Oh, no. Okay. Okay. Good evening, everyone. Thanks, Matthias, for the introduction. As Matthias said, before I worked working as a clinical perfusionist in ZNA Middelheim, I've worked as 10 years as an anesthesia technician in Breda, Pathofysiology in Breda, in the Netherlands. Today, I'm going to talk about hyperthermia in anesthesia and cardiopulmonary bypass. I think it is important to talk about this subject because Matthias said it also is rare. Here is an. Okay, wow, it works. This is a table of contents where we're going to talk about today. You can call it the menu. We have 10 courses. Before we begin, I'm going to give an introduction about hyperthermia, what it is. So let's get on with it. As we already said, hyperthermia is rare. Some anesthesiologists say, I've never seen it in all my 35 years of career. In my case, I saw it once with a young male when I worked as a OR specialized nurse in Klina in Brasschaat. And it was heavy to see that. It is rare. Therefore, the recognition of hyperthermia by the anesthesiologist is difficult. And even more for the perfusionist. Why that is, I will talk about that later. Also, I think it's very important to have knowledge of signs, symptoms, and treatment of MH. And also knowing the MH protocol and logistics within your own hospital. When I asked my own hospital, where is the Dantrolene, there was a little doubt from, do we know that? But okay, that's for later. A little bit about the definition of hyperthermia. Hyperthermia occurs as a hypermetabolic state. When a MH suspect individual is exposed to volatile anesthetic gases, so it's an allergic reaction to sevoflurane, desflurane, and isoflurane. The most common used anesthetic gas, I think, is sevoflurane. That's a little bit less, and I think there are no hospitals anymore that use isoflurane, but I can be mistaken. And so a special one is succinylcholine. I'm going to pronounce it as a depolarizing muscle relaxant. The mechanism of action of succinylcholine is different from Nimbex or rocuronium, because it has a direct action to the muscle. It excites its excitation the muscle. So there is also an excitation of the rear, the ryanodine receptor. The problem with myelopathy, the big problem is the genetic disorder of the ryanodine receptor. I'm going to talk about this receptor later. The incidence, all I have said, it is rare. MH occurs in 1 in 100,000 performed, 100,000 performed anesthesia, so it's very, very rare. It's more in men than in women, 2 on 1. Surprisingly, 48 to 50% of the confirmed cases of myelopathy are in children under the age of 19. Why that is important, I will tell you later for the logistics. There is no difference in ethnicity. There's something debate about that. Some people say no, you see it more by North African people. Others say it's more for the Caucasian. I can't find evidence if this is more for a specific group of people. So it's all over the world. You see it all with all races. If you want to understand what the problem is with MH, you have to understand the normal muscle physiology. When there is a depolarization of the muscle, calcium will enter the intracellular space from the sacroplasmatic reticulum. It's a difficult word, so just let's call it SR. This mechanism is controlled by the RIR1, the ryanodine receptor. It is also located in the sacroplasmatic reticulum. So the calcium influx intracellular is organized by the RIR1. After contraction, calcium leaves the intracellular space back to the SR. This is an active process. ATP is needed for that. So hypermetabolic, there you have it. When the calcium is out of the muscle, then the muscle relaxes again. I'm sorry, I'm a little bit nervous. What is the problem with MH physiology? In an MH suspectable patient, there is an abnormality in the RIR1. We also said it was a genetic disorder. This causes unregulated passages of calcium into the cellular space. So you get a huge amount of calcium influx into the intracellular space, followed by a sustained contraction of the muscle. So it's calcium, the muscle stays contracted. Of course, the body will try to pump out of the excessive calcium back to the SR. Therefore, a huge amount of ATP is needed. What are the clinical presentation of MH? As I always said, it is in hypermetabolic state. And this one is a tricky one. What do you see first? Do you see an elevation of the body temperature, or do you see an elevation of the entitled CO2? Also, the first sign that you see by MH is a huge elevation of the entitled CO2. You can see that on your capnography on the anesthesia machine. For the perfusionist, you can see that on your CDI or on your blood gases, your ABGs. That's rising of this CO2 entitled can't be explained. So you can't say when it's from when you have CO2 in the field, you have CO2 from the laparoscopic operation. And you will see that within minutes after induction. And followed by increase of core body temperature. That will be seen later than a CO2 elevation. Most of them cases, the body temperature will rise about 41 degrees. Because you have a hypermetabolic states, the muscles stay contracted. there will be a skeletal muscle rigidity and a masseter muscle spasm as a result. The last one, the masseter muscle spasm, you see in 90% of the cases. So it's a typical sign for malignant hyperthermia. Other signs are tachycardia, increase of the O2 consumption by hypermetabolic states, acidosis, and rhabdomyolysis. Okay. Here is a sign of where the masseter is. This, you have a contraction of the jaw. You see then, of course, if there is a tube, that will be a problem. Here I have a case report. It's a case report from a young male that is having a MH crisis. I don't know if my will work. So I will have to let's see without the audio, I think. So I don't know if you hear the sound, but it's not. Okay, it's about a black male, 23 years old, 80 kilos. Is for anterior cervical gunshot, and the rest you will see. Here is isoflurane used, okay. Atropine. Here you see after 40 minutes, 38 degrees, end-tidal CO2 is rising rapidly. And then you see about 60 minutes, huge end-tidal CO2 temperature is rising above 41. Acidemia, hyperkaliemia. Voila. And here you will see a video from intraoperative. Voila, tachycardia as a sign. Then the anesthesia, and you see there 123 end-tidal CO2. And then high level, 100% oxygen and 15 liters of gas per minute. Here is a intraoperative. The Dantrolene, we'll talk about that later. And also crush ice on the patient to cool him down. You see the intraoperative graphic trends. So if you're fast, you can reverse it in hours. Huh? Voilà. He didn't make it, and that's very important. Huh? Okay. Before you think about MH, it's very important to look before something. Is there insufficient anesthesia? Is there enough analgesia? Is there much insufficient ventilation? Is there enough fresh gas flow? And sometimes that I already mentioned, increased CO2 absorbing during laparoscopy. Yeah? That could be, and of course, something very simple, fever. Okay. There are some syndromes and diseases that look like malignant hyperthermia, but they aren't. Sometimes you see neuroleptic malignant syndrome, serotonergic syndrome, Fiochorome storm, Terowitz storm, and iatrogenic overheating. Yeah? Those are 5 of the differential diagnoses you can see in case of malignant hyperthermia. Okay, the most important thing, treatment. What are we going to do when we have a crisis of malignant hyperthermia? One and foremost important thing is call for help. All hands are needed. Get the Dantrolene as fast as possible. Start dissolving Dantrolene with sterile water for injection. Why start with that? Because the dissolving of Dantrolene is tough. It takes a lot of time and a lot of effort to reconstitute Dantrolene before you can administer it. Of course, with synchronic, stop the volatile anesthetic gases, start TIVA, ventilate the patient with 100% O2 on high flows, as you saw in the case report, and cool the patient active. For the anesthesiologist, that is us. For us as perfusionists, we can take advantage of our heater cooler. And then start the treatment for acidosis and coagulopathy and all the rest that comes from the problem from the hyperbolic metal state. This is teamwork. If you are a team, you can do this. This is very important. Something about Dantrolene. What is Dantrolene? Dantrolene stops the calcium influx by blocking the RIR1. So it's nothing more or nothing less than a muscle relaxant. Dantrolene is also used with children that have muscle disorders. So they have muscle contractions, and they use that for that. Okay. In the Netherlands, there is a stock. It's required by law to have a stock of 36 vials in the OR. I don't know what it's in Belgium, but I think it's also in Belgium required by law. Each vial consists of 20 milligrams of Dantrolene. You have to dissolve the content of each vial with 60 milliliters of sterile water for injection. Why put that in? There are not as much hospitals that have sterile water in large amounts. When I asked the Amphia hospital, do we have sterile water for this? Oh yes, we have it. We have it in bottles of 10 cc. It said if you have to have, if you look at the dose of 25 milligrams per kilo body weight, if you have someone from say 100 kilos, yeah, you will need 10 to 15 of those bottles, of those vials of Dantrolene with 60 milliliters of sterile water. You will need 600 to 1 liter of sterile water for injection. So not in all hospitals you have this in large amounts. As I said, difficult to dissolve. Therefore, do this with 3 to 5 people. So you have people who take care for the patient, and then you have a team who dissolves the Dantrolene. You see the Dantrium, the vial, the reconstitution of it, in vials of 60 milliliters in 50 milliliters syringes. You also have Ryanodex. Why do I put this in presentation? Because it's a new sort of Dantrium. It has 250 milligrams in a bottle, where Dantrium has 20 milligrams. So Ryanodex, you also have You just have to have 5 milliliters of steril water to reconstitute that. The only thing is, if you look at the price, vials required to stock is 36. The price of that is 3,000 euros. For 3 bottles of Ryanodex, it's $6,900. So it's a lot cheaper, a lot expensive, and it also has a shelf life of for 2 years. The diagnostic test for malhyperthermie. Sorry, I'm going to drink. How is it diagnosed, malhyperthermie? Well, it's the diagnostic test is usually performed when there is a family history or any suspicious signs during previous anesthesia. In the Netherlands, there are specific families that are known with the RIR1 disorder, the genetic disorder. This is done by the caffeine halo-10 contracture test. This can be done from the age of 4 years and from a body weight of 20 kilograms. For this contracture test, they take a muscle biopsy from the vastus lateralis. It's on the thighs. This biopsy is then exposed to the caffeine and halo-10 test. When it's positive, it's definitely MH. This one I'm not sure about, but it's performed in specialized center. One of that I'm sure of is that it's in the University Hospital of Antwerp, and they have a special MH laboratory where they can perform these tests. The caffeine halo-10 contracture test is the gold standard for malign hyperthermie diagnosis. Logistics, I think that's important. Why? Because there you can have a problem. A good MH protocol falls or stands with the logistics. As a few slides back, I said you need a lot of those files. So you have to know what the MH protocol is in your hospital. Where is the dentrium and how many vials are there? If you have a hospital, are there more sites in the group, and where are they? And of course, what is the logistic protocol to initiate when MH occurs? We had this problem in Amphia Hospital, so I asked my doctor, do you know where the dentrium is? Yeah, I know it exists. I know that we have it, but I don't know where it is. I think it's in the closet, some there, and yeah, okay. So yeah, let me see. Okay, let the bottle see. Oh yeah, we have 10 of them, and they're overdate. So that was a huge problem. Called the pharmacist, and I asked him, do you have steril water? Yeah, we have it, but not in large amounts. So then we said we have a serious problem here. When there is an MH crisis, we're not prepared for it. So we inventorized where the dentrium was. The Amphia Hospital in Breda has 3 sites. One is a trauma center, one daycare hospital we have, and then also we have the Mother-Child Center specialized in childs. And we made for that hospital what we called the MH case. What is it? We just made it a case, and it's on every site there was a case with the vials in it. Here you see the case of the Langendijk. This is the children's hospital. We had here 20 bottles in the case, also a couple of syringes, and the steril water in the case. Why in a case? Because it's easy. You put it in a case, you put it central in a space where the medication is, and everyone was trained to know where it was and what to do with it. So I think it was in the last year when I worked there. They said, I think we have the next one is a suspicious case. I think he had MH signs last operation. So let's initiate a protocol. So when the protocol is initiated, people of the logistics are jumped into the car, and they go to the other sides and they just ask, please give me the MH coffer. Everybody on the ward knows what it is and where it is. So that was the logistics. So in 20 minutes, all those three cases are on one side. So we had 46 vials per hour on site for this case. So it's important that you think about the logistics. In our hospital, in Milan, I also asked the same question: where is the Dantrolene? Well, here it is. My head nurse said, "Oh, I think it's in operating room 5 in the closet." And she opened, yeah, and there it was. But also bij ons in Zetten Middelheim Hospital, everybody was noticed from, okay, there is a Dantrolene on the ICU in the medication closet. Is the rest of the Dantrolene, and also the sterile water for injection is also at the ICU. So that's the protocol there. Voila. Now a little of MH and the clinical perfusionist. I said in the first slides, it's difficult for the anesthesiologist, but for the perfusionist, it's more difficult to recognize it, because most of the signs and symptoms are masked. We call the patient active, so the rising of the temperature will not seen as fast as normal at the anesthesia. And we also use the CO2 in the operating field. If we think about valve surgery, there is CO2, it will come from the CO2. But sometimes it's also mentioned in the literature, due to the increase of PaCO2 or entitled CO2 and a decrease of O2, it can be difficult to separate it from something. And I think everybody knows it. If you see the last sentence, what it's all about, oxygenator failure, the worst nightmare of a perfusionist. But when a crisis, when you're on pump and you have an MH crisis, the CO2 will rise and the O2 will drop fast, very fast. So the first thing you think, I think there's an oxygenator problem. In 90% of the cases when these occur, it will be an oxygenator failure, but in that 1%, it could be MH. Voila. The take-home message for the most I want to give you is that even if it is rare, that it exists. You won't see it, but if you see it, know that it exists. Also, you will need all the hands that you can get to help to reconstitute the Dantrolene. And also what I would recommend is take a look around in your own hospital where the vials are stored, because if I ask 20 people, 19 will not know it. They don't know what MH is. They don't know where the Dantrolene is. So if a crisis occurs, you must act fast. And if you have to search for the vials, it won't be easier. And also the knowledge of the MH protocol, if there is any. In the Amphia hospital, we made a protocol. We put up a sort of how do you call it, lessons that were repeatedly given, and also it was repeated yearly, so everybody knows what it is, what it was, and where it is, and how to act. Voila. I think that's what I wanted to say. Thank you all for your attentions. Are there questions?
Thank you, Dimitri, for this wonderful presentation. For the moment, there are no questions, but I have some. Are you aware of any cases on bypass that it had happened and that it's published?
There are some cases reported, yes. But if I ask some perfusionists, did you have seen it? They say, no, I didn't see it yet, but yes, there are confirmed cases.
Okay, thank you. And in the event that there is no Dantrolene available, and could it be possible to manage it with CPB by cooling and by increasing sweep gas flow to eliminate CO2? And how long will it take after stopping the volatile anesthetics before the effect is gone from the malignant hyperthermia?
The effect will stay. That's the problem with it. One moment. Okay. The problem is the only action you can take is the Dantrolene. The real one has to be stopped. So you can give some high gases. You can blow off the CO2, but the problem stays. So normally the Dantrolene must be administered in 20 minutes. So if there is no Dantrolene, it's simple but hard, the patient dies. So the mortality of MH is very high. The case I saw 20 years ago was, I think it was a male person from 16 years old. He was dead, and it was very fast. In an hour, he was dead.
Okay.
So that's why I'm so. I find it important that everyone knows about it.
Okay, thank you. If there are no further questions, oh, there's one. When Dantrolene is administered to mitigate the changes of temperature, could it be helpful to put a non-cardiac surgery patient on CPB to cool down while you wait till the Dantrolene does its job? Or is cooling with ice on the legs or
I think ice on the legs is more effective than you have to do a sternotomy. You could do an ECMO. You could do that. I think that's more easier, and then you can cool active the patient. But I think there is no time for that. If it occurs, you have to act fast. And in Amphia Hospital, there was a protocol. When it occurs, we have an ice machine. Okay, we had there an ice machine, and there are buckets ice brought to the OR to cool down the patient. So yeah, it would be ideal to put the patient on the extracorporeal system to cool him down, but I think that's not the general practice today.
Okay, thank you very much. There are no further questions. So I think we can round up here. In September, there might be another webinar, but we hope we can welcome you all back to the Bowling Stones in real life, and that the COVID measurements are over. Okay, all a good evening, and hope to see you soon.
Thank you.
Oh, there is one last question.
Mm-hmm.
No. Okay, thank you, Dimitri, and good evening.